The next thing to understand, an important concept is about the globin chain synthesis. That is very important because this is not practically that important, but theoretically very important to understand the disease like thalassemia and all these things, which is a disorder of globin chain synthesis. So let us see what will be the problems in the globin chain synthesis. So in this, to start up with, I have put up the same image which you have seen in the last video. So you can see one thing, that the adult hemoglobin, that is HbA, is going to contain two chains, that is alpha chain and beta chain. Normally globin is said to be something called a tetramer, so it should contain two chains from each category. So normally a globin chain is said to be a tetramer. It should contain two chains from each particular gene, that is alpha gene as well as beta gene, which give rise to two alpha chains and two beta chains, which together forms a tetramer, forming a globin chain. And to this only you have attachment of the heme. So this is what we call the heme, this blue color thing, and together you attach the heme and you form the hemoglobin. That's how it works. So if you ask me, I already told you about the oxyhemoglobin and deoxyhemoglobin varieties and also how 2,3-DPG affects the oxyhemoglobin and deoxyhemoglobin properties, and 2,3-DPG is going to just increase the oxygen release and shift the oxygen hemoglobin dissociation curve towards the right. So that's what is going to happen. But here, since we are moving on to the core things on globin chain synthesis only, we will remove all these things from our understanding and we concentrate only on the globin chain synthesis and what are the types of the globin chains. So we have a lot of types of hemoglobin. The adult hemoglobin is what we call as HbA, that A stands for adult. It's an adult hemoglobin. Normally an adult contains almost 98 to 99% of the hemoglobin tends to be HbA only in a normal adult. But it's not the same. In fetal period and embryonic period you have a different hemoglobin, and by birth, like the globin dynamics is the one that's going to continuously change over time. So let us see. So the globin, in the sense, it comes from two separate genes. One is the chromosome number 16, and second one is the chromosome number 11. Second is the chromosome number 11. So why I am writing in this way, you will understand in some time, because chromosome number 16 contains 4 different genes. For example, you have something called an alpha gene and you have something called a eta gene. So 2 different genes, sorry for that. So alpha and eta. And chromosome 11 contains 4 different genes. That is, you have a beta globin gene, and then you have something called a delta globin gene, and you have something called a gamma globin gene, and you have something called a epsilon globin gene. So you have 4 globin genes. Usually it is a combination. Usually how it really happens is the synthesis of the globin and the hemoglobin depends on the combination of the chromosome 16, product of chromosome 16 with the product of chromosome 11 that gives rise to the actual globin. So for example, if you ask me, if there is a combination of the alpha, the 2 chains, and you have a combination of the beta, 2 chains, and this is 2 alpha and a 2 beta, and this is what we are going to call it as a HbA. This is the adult hemoglobin. So if you ask me about what is the percentage of the adult hemoglobin, I already told you, almost it is 98 to 99%. A standard adult, 98 to 99% of hemoglobin in an adult is going to be your HbA only. But in newborn, if you see, the moment you see in the newborn what are the types of hemoglobin, almost only 15% of the hemoglobin is HbA and almost 85% is going to be hemoglobin F. So we'll see what are all those. So if you put a combination of these two, eta 2 and beta 2, for example, I'm going to put 2 eta genes and 2 beta genes. So this hemoglobin is what we call as something called Portland 2, and this hemoglobin is what we called as Portland 2. And as we all know that this is not of that much important for adult, this is an embryonic hemoglobin. As simple as that. These chains generally come from the yolk sac. Apart from that, this hemoglobin is not important to understand at all. So then if you put 2 alpha and then you put 2 delta chains, and this is what we refer to as something called a hemoglobin A2. So usually what happens, what is the importance of hemoglobin A2? Hemoglobin A2 is important, only in diagnosis of maybe a thalassemia minor. Apart from that, hemoglobin A2 is not that important in clinical practice. But generally, if you ask me, in the standard adult, the hemoglobin A2 contributes to approximately 2 to 3%. This is normal. The moment it exceeds more than 3.5 percentage, it is very important for diagnosing thalassemia minor, especially a beta thalassemia minor. Very, very important. This is a very important point. I'm going to repeat this point again and again. When HbA2 levels are more than 3.5 percentage, it is going to clear-cut give the diagnosis of a thalassemia minor. And you have these two hemoglobin, that's called delta delta, and you have eta eta. Is there any hemoglobin like that? Actually no, there is no hemoglobin like that. So this combination is not seen in the humans, I mean even in the embryonic period. So don't you have to know that this delta and eta combination is not at all available in the first place. Then if you take this one, if you have 2 alpha and combine with this 2 gamma, this becomes something called a hemoglobin F. This becomes something called a hemoglobin F. This is a fetal hemoglobin. Fetal hemoglobin, you know very well, it is going to have a little bit more affinity to oxygen compared to the adult hemoglobin, and it is the one that is going to shift the oxygen hemoglobin curve a little bit to the left. But apart from that, fetal hemoglobin, if you ask me, almost 100% of the hemoglobin will be fetal hemoglobin by around 5 to 7 months of age. But at the newborn time, I mean around 7 months of age is the 5 to 7 months is the time where the beta chain production itself will start in the child, in the fetus. So by birth, if you ask me, 85% will be the HbF and only 15% will be the HbA. But the transitional shift, that the gamma chains will decrease, which means the beta chains will get increased in production, which means HbF will decrease because of the decreasing in the gamma chains, and HbA will increase because of the increase in the production of beta chains will happen. This shift, transition from HbF or gamma chains to HbA or beta chains is going to happen by approximately 3 to 6 months of the postnatal age or after birth, 3 to 6 months. So this is where the time of the shift, which I'm going to discuss in a completely separate and different diagram. So these are some of the importance of the HbF. A lot of conditions may have excessive HbF, like even sickle cell disease can have HbF, and there is a disease called hereditary persistence of fetal hemoglobin. In thalassemia major or intermediate, HbF may be increased. So there are a lot of conditions where HbF may be increased even in adult life, but we are not going to discuss right now. We are going to see a lot of stuff about those things in the thalassemia section. So then if you put 2 gamma, if you have 2 eta chains and you have 2 gamma chains, so this hemoglobin is what we refer to as something called a hemoglobin Portland 1. So this is what we refer to as Portland 1. As you all know that this is also a type of only embryonic hemoglobin. That's it. So then if you have 2 alpha and you have something called 2 epsilon chains, and this 2 alpha and 2 epsilon is what we refer to as something called a GOVER2, and you all know that this is also an embryonic hemoglobin, and it's only important in the embryonic period. Apart from that, it's not that important. And next, if you ask me, then next step, then you have 2 eta chains and you have 2 epsilon chains. So this 2 eta chains and 2 epsilon chains, you can call zeta chains also, 2 zeta chains and 2 epsilon chains together contribute to another embryonic hemoglobin, something called as GOVER1. This is a GOVER1, and you have this another embryonic chain, another embryonic hemoglobin synthesized only during the yolk sac time. So apart from that, these hemoglobins doesn't carry that much weightage at all. So these are the different combinations. That is the reason why I put initially chromosome number 16 and here chromosome 11, because the combinations are what is going to happen. So the one combination you don't have is the zeta or eta chains with the delta chain. That combination hemoglobin is not seen in human beings, but remaining all combinations you can give. Apart from the most important things are alpha and beta combination, alpha and delta combination, and alpha and gamma combination. Remaining almost all the combinations are going to result only in a embryonic hemoglobin, which is going to be there only for the first 2 to 3 months around. Apart from that, there is no much importance for those chains. Okay, so with this thing, you can go on to the certain numbers which are very important. So what are the numbers that are very important? If you ask me, till 6, for the example, first 6 weeks, you can see the predominant site of hematopoiesis. I already told you it must be the yolk sac for the first 6 weeks. That is the site where the hemoglobin synthesis starts from, and typically the yolk sac is going to produce something called embryonic hemoglobin. You all know that. So typically the yolk sac produces embryonic hemoglobin only. From 6 to 30 weeks, 6 weeks till 30 weeks, usually this embryonic hemoglobin will be completely replaced by fetal hemoglobin. That is alpha 2 and gamma 2 chains. So 2 alpha and 2 gamma. So this is what is going to predominate. That is the fetal hemoglobin up to 30 weeks. Usually around 30 weeks mark is the time where the transition into beta chain starts and the HbA starts increasing. So which means from 30 weeks till birth. So after 30 weeks, at 30 weeks if you see, for example, what will be the numbers at around 30 weeks of time? If you ask me your HbF is to HbA ratio, your HbF is to HbA ratio is approximately 95:5, which means 95% at 30 weeks time, 95% will be hemoglobin F and only 5% will be hemoglobin A. If you ask me what will be the percentage distribution at birth, if you ask me the same HbF is to HbA percentage, it's going to be 80:20 or 85:20. 80 to 85 is to 15 to 20. So which means 80 to 85% is going to be the fetal hemoglobin only. 80 to 85% is going to be the fetal hemoglobin and only 15 to 20% will be the adult hemoglobin, that is HbA. But when the overtake starts, but if you ask me but around 30 weeks in the postnatal period, 30 weeks in the postnatal, that is after 6 months, the postnatal period, you can see the same HbF to HbA ratio will be somewhere around 98:2 approximately, which means 98% will be HbF and only 2%, I can write as 2:98. So 2:98. So which means 98% is going to be HbA and only 2% is going to be HbF, which means by around 30 weeks of the postnatal period, the transition from alpha to gamma is complete. Gamma to beta is complete. That is transition from HbF to HbA is complete by around 30 weeks of postnatal age. So this I can put it in a picturized form in this particular image. What you can see is in chromosome number 16, you have your zeta or eta chains along with the alpha chains, alpha globin genes, and in chromosome number 11 you can see 4 different globin genes, that is epsilon, gamma, delta and beta. So this is what is going to happen. So these are the 4 things which I have discussed already. So the combinations I have told you, different combinations we have given already. The cover 1, cover 2, Portland 1, Portland 2, then you have HbF, HbA, HbA2, all the combinations we have mentioned here. So you can also see in this particular, the bottom one, you can see one thing. So you can see the sites of hematopoiesis we have given on the top. These are the sites of hematopoiesis and what are the relative chain ratio also we have given. For example, you can see the alpha chain increases during the embryonic period itself and remains stable throughout the life. The alpha chain synthesis is not something that's going to differ at all. It increases during the embryonic life itself and it's going to remain completely stable. But if you see all the embryonic chains, this epsilon chains, this zeta, eta chains, all these things regress during the first 6 weeks itself. In the first 6 weeks itself, this embryonic hemoglobins will regress and that marks the beginning of your adult hemoglobin. Gamma chains. That marks the beginning of the increase in the gamma chains by around 6 weeks of age, where after that your predominant hemoglobin type will be HbF because you have alpha chain along with the gamma chain. So this is what we refer to as something called a HbF. And next, if you see, beta chain synthesis will start around 6 weeks by the same mark, but if you ask me, it starts increasing only by around 30 weeks. This is the transition point. So this is where the time the beta chains start increasing in production, and this is where the time your gamma chains also start decreasing in production. So which means by 30 weeks of the fetal life, that is the time where your HbF will start decreasing and your HbA will start increasing. If you ask me at birth again, at birth you can see still the HbF, this is at birth, still the HbF is actually more, which means HbF at birth is going to contribute to almost 80% or 85% and HbA is going to contribute approximately like 20% during birth. But in the postnatal period you can see but by around 6 weeks of age, if you ask me, this is the 6 weeks mark and the transition is almost going on, and by around 30 weeks mark your transition is nearly complete, where the HbF has completely regressed to almost baseline value, that is approximately less than 1 to 2%, and HbA has become a predominant hemoglobin, that is approximately more than 98 to 99%. So HbA has completely taken over by around 30 weeks of postnatal age. So this is a very important image to know. So where in the during the embryonic time, the first 6 to 12 weeks, you have completely embryonic hemoglobins and embryonic chains produce that zeta and epsilon are the ones that are synthesized. Alpha kicks up in the embryonic time itself and it remains stable throughout time. But the zeta and epsilon will come down over time and your gamma will pick up after that after the embryonic period, and by around 30 weeks of the fetal life, your beta chains will take over. So start picking up, and by 30 weeks postnatal, the transition is complete and your HbF will be completely transformed into something called HbA. That is the major hemoglobin in the body. So by knowing all these things, the next thing what you have to see is what are the hemoglobins that have high affinity and low affinity. But different diseases will have different levels of the hemoglobins, but it's also imperative to know what are the different high affinity and low affinity hemoglobins. If you see what are the different types of hemoglobin. So hemoglobin types, if you ask me, you can tell something called HbS, you can tell something called HbC, you can have something called HbD, you have something called a HbE. So these are some of the variants of hemoglobin. These are some of the hemoglobin variants. The affinity for oxygen can vary and the properties of the hemoglobin can differ depending on what is the type of the hemoglobin. So whatever I mentioned, these types of hemoglobin are usually due to point mutations. In the beta globin chain. Point mutations in the beta globin chain. Best example to understand is something called a HbS. That's one of the best examples to understand, because in HbS, in the beta globin gene, in the 6th position, you have something called a glutamate that is going to get transformed into valine. This is the point mutation. That is, you have a mnemonic also, isn't it? Remember, glutamate go valine va. So you have a mnemonic for that. So the glutamate goes and valine comes va. So this is what is going to happen. So glutamate to valine transformation happens. This creates some of the changes in the properties of the beta globin chain itself. So that is the one that is going to cause a sickle hemoglobin. That is the one that is going to cause something called a sickle hemoglobin, which we know already. So all these things are very easy. Similarly, you have point mutations in everything. You have HbC, the point mutation. HbD, you have a point mutation. Similarly, in HbE also you have a point mutation. So we'll discuss in the thalassemia and sickle cell anemia topic. But apart from that, so these are some of the hemoglobin type. Similarly, these are the actual variations, the properties of the hemoglobin. But there are certain variants that affect oxygen affinity. At the same time, there are variants that make the entire hemoglobin itself unstable. So these are called as unstable hemoglobins. What are the things that affect the affinity for the, affinity of the oxygen towards the hemoglobin, or hemoglobin affinity for the oxygen? Either way, it's correct. So what are things that increases the oxygen affinity for the hemoglobin? The classic example is carboxyhemoglobin, which means when carbon monoxide is bound to hemoglobin, the oxygen affinity is going to, the carbon monoxide affinity is going to be, oxygen affinity is going to be 256 times more for carbon monoxide compared to the oxygen. So it will not leave. So the hemoglobin affinity for carbon monoxide, this is high affinity mutants, isn't it? So then you have something called methemoglobin, which again has a very high affinity. At the same time, you have something called example, HB Chesapeake is there. And again, this is one characteristic example of hemoglobin having a high oxygen affinity. Similarly, you have something called unstable hemoglobin. What do you mean by, similarly you have something called hemoglobins with reduced oxygen affinity. What are the hemoglobin that can have reduced oxygen affinity? For example, you have something called HB Kansas. This is one example of a hemoglobin which have reduced oxygen affinity, which means whenever you have increased oxygen affinity, the ODC will shift towards the left. Whenever you have reduced oxygen affinity, the oxygen hemoglobin dissociation curve is going to get shifted towards the right. So this is what is going to happen. So similarly, you have a lot of unstable hemoglobin also. So what will be the unstable hemoglobins? So if you have unstable hemoglobin, the classic example of HB cone. So that's called HB cone, KOLN, cone. And this is supposed to be the most common unstable hemoglobin in the world. But even though the incidence itself is very rare, but it is the most common unstable hemoglobin in the world. Similarly, you have a lot of other hemoglobin like HB Zurich, HB Tacoma, HB Biba. Lot of unstable hemoglobins are there which are extremely rare, and they are named only after identifying these hemoglobins from a particular place. These are all place names, isn't it? So it's a very, very rare thing. And what unstable hemoglobins do generally is, whenever you have an unstable hemoglobin, they are going to precipitate as Heinz bodies, and presence of unstable hemoglobins also can give rise to formation of bite cells or blister cells in the peripheral smear. So all these are absolutely possible and feasible. So these are some of the variants of hemoglobin, right? So what we have discussed till now is about the globin chain synthesis, different genes that are involved in globin chain synthesis, what are the types of hemoglobin itself depending on the changes in the number, changes in the components of the chains that are present within the hemoglobin, and what are the hemoglobin variants, types of hemoglobin that are having point mutations which changes the characteristics of the hemoglobin molecule itself. And next thing we have seen about the hemoglobin with affinity variants like increase affinity or decrease affinity, and we have seen unstable hemoglobins also which are going to precipitate as Heinz bodies. So these are some of the important things to understand. So next thing what we are going to see is on the oxygen and CO2 transport. Oxygen and carbon dioxide transport. So we are going to discuss in short about the Bohr effect, Haldane effect, and double Bohr effect and all these things, but still it's quite important now. So I am not going to discuss in detail about all these things, just a crisp overview of what is going to happen with all these things. So number one, oxygen, how it is carried. For example, if you ask me oxygen transport in the blood, oxygen transport in the blood. So if you ask me, 98% of the oxygen is transported in the blood in the form of hemoglobin, which is coupled with hemoglobin. This is what we call as oxyhemoglobin. So 98% is transported in the form of oxyhemoglobin only. So remaining 2% is transported as dissolved oxygen. Remaining 2% is the one that is going to be transported as dissolved hemoglobin. 98% is going to be transported as oxyhemoglobin only in the form of oxygen and hemoglobin connection. So this, if you ask me, for example, what is the applied thing for that? If you ask me, how will you measure whether how much oxygen is bound to the hemoglobin or not? This is what you're going to find out by something called a SpO2. This is what we call pulse oximeter saturation. Saturation of the pulse oximeter. If you ask me how you are going to measure the dissolved oxygen, how much is the dissolved oxygen? You are going to measure something called PaO2, that is called partial pressure of arterial oxygen. This small a stands for arterial, partial pressure of arterial oxygen. That is the key for you are doing an acid base analysis. Or alternatively, this oxygen bound to the hemoglobin can also be found by SaO2. So now I have told three components: SaO2, SpO2, and you have something called PaO2. So whenever you write SaO2, this means it is the arterial oxygen saturation. Arterial oxygen saturation of hemoglobin. So that's what we call SaO2. There's not much difference between SaO2 and SpO2. Most of the times it's going to be the same. There won't be much difference. But the principles, how they work are different. So saturation of oxygen in the hemoglobin, by directly measuring, that's what you do in ABG. If you do by ABG, what you're going to get is the SaO2. So you're directly taking the arterial blood and seeing what is the saturation by spectrophotometric principle. So that is completely different. But what you see by pulse oximeter is completely different. So pulse oximeter depends on the wavelength analysis and how much is the light that is absorbed. That is called Beer-Lambert law, which we are going to discuss in the subsequent section. But apart from that, this is what you have to know. Oxygen that is bound to the hemoglobin, how much hemoglobin is saturated with oxygen, that can be measured by SaO2 or SpO2. SaO2 is measured by ABG analysis. SpO2 is by pulse oximeter, simple non-invasive pulse oximeter. And how much oxygen is dissolved in the blood can be determined only by ABG, that is through PaO2, finding out the PaO2. That is called partial pressure of arterial oxygen. Then you have CO2 transport. CO2 transport, if you ask me, in what way the CO2 is transported, 75% of the CO2 is going to be transported through plasma bicarbonate. Bicarbonate is the one of the most important ways of how to transport a carbon dioxide, 75%. Then if you ask me, around 20% is bound to hemoglobin in the form of something called a carbaminohemoglobin. So please don't write this as carboxyhemoglobin. This is what we refer to as something called a carbaminohemoglobin. So 20%. Around 5% approximately is circulating in the form of, transport in the form of a dissolved carbon dioxide, and this is what we are measuring in the ABG in the form of PaCO2. PaCO2, that is the, how much carbon dioxide is dissolved in the blood. So that's what you are going to find out by something called PaCO2. So these are the basics. So this is how oxygen and hemoglobin are getting transported. So apart from that, you have a lot of things on hemoglobin itself acts as a buffer system. One of the important buffers for acidosis is hemoglobin, protein buffer. Then hemoglobin, bicarbonate is also, where the carbon dioxide transport is also an important buffer mechanism for the lungs, isn't it? So because we have a whole lot of something called bicarbonate buffer system, one of the most efficient buffers in the body. That is what we call bicarbonate buffer system. So a lot of things are there. So the basics of the buffer and acid-base balance is discussed separately in the acid-base section in the nephrology part. But apart from that, like this, I think enough for knowing the current thing, so which is the hemoglobin problems. So next thing, when you want to know, we have to know about the Bohr effect and the Haldane effect, which is by a single diagram we can explain the Bohr effect and the Haldane effect. So this image is the one that's going to tell you the Bohr effect versus the Haldane effect. So I can tell this is an example of a Bohr effect which happens in the periphery. And second thing, you have something called a Haldane effect that happens in the lung. So this is the Bohr effect and this is the Haldane effect. So what is the principle of the Bohr effect? The principle of the Bohr effect is nothing but oxygen affinity of the hemoglobin is inversely proportional. Oxygen affinity of the hemoglobin is inversely proportional to the amount of carbon dioxide and the amount of hydrogen ions. So that is very important. So the moment your carbon dioxide or hydrogen ions are increasing, your oxygen affinity for the hemoglobin will decrease, or the hemoglobin's affinity for the oxygen or oxygen affinity for the hemoglobin will decrease. So the oxygen will be released. So that's the idea. So this is what we call Bohr effect, and it's going to typically happen in the peripheral tissues, where the tissues will contain a lot of carbon dioxide. Which diffuses into the cell RBC, and it's going to form carbonic acid. So this is called carbonic anhydrase enzyme. So this is going to form something called a carbonic acid, that is H2CO3, carbonic acid. Carbonic acid is, very well, it's very unstable. At the pH of 7.4, carbonic acid should, again the basics of all these things we have discussed in detail in the acid-base chapter. But if you ask me, this H2CO3 at pH of 7.4, that's a neutral pH of the body, is going to immediately get dissociated into H plus and HCO3 minus. So that's what is happening here. It's dissociated immediately into H plus and HCO3 minus, where this H plus is going to bind with the hemoglobin, because hemoglobin is also very efficient buffer. So it's going to bind with the hemoglobin. Once it binds with the hemoglobin, it forms something called a, like this oxyhemoglobin is going to become something called hemoglobin with H plus. So the once, the H plus concentration is increased, so definitely your oxygen affinity will decrease, and because oxygen affinity decreases, the O2 is released into the peripheral tissues. And this is a very simple diagram. So CO2 movement into the RBC, because of high concentration of CO2 in the peripheral tissues, is going to push oxygen out of the RBC and binds with the H plus instead of CO2, obviously. So it binds with the H plus. So by pushing oxygen out of the hemoglobin, so the oxyhemoglobin becomes a deoxyhemoglobin, and this is the principle. So oxygen is delivered to the tissues. The oxygen delivery happens in the tissues. So what do you mean by Haldane effect? If you ask me what do you mean by Haldane effect, Haldane effect is something little bit relatively different. So in Haldane effect, what they are telling is the carbon dioxide affinity for a hemoglobin is inversely proportional to the presence of oxygen. So which means if the oxygen in the tissues are, oxygen somewhere is increasing, the carbon dioxide affinity will decrease and the carbon dioxide will be released and the oxygen will be taken up. So this best example happens in the alveoli, where the venous blood is containing low oxygen and the alveolar air is going to contain a lot of oxygen. So the oxygen concentration is increasing. At the same time, carbon dioxide would have been expelled in the last breath, so the carbon dioxide also will be very little in number compared to what is there in the blood. So by this principle, what happens is, again, your oxygen diffuse into the cell, because oxygen is in very high concentration in the lung, in the alveolar regions. So this will convert the hemoglobin with hydrogen ion that is already mixed during the previous peripheral tissue, that's going to get converted to something called a oxyhemoglobin because of the mixing of the oxygen. So this H plus is going to combine with bicarbonate within the cell to produce something called a carbonic acid. This carbonic acid, again at a pH of 7.4, it's always going to dissociate into H plus and HCO3 minus. But in the presence of this carbonic anhydrase enzyme, this can shunt towards production of CO2 and H2O. This CO2 is once again eliminated out of the RBC and it is exhaled outside through the lungs. So this is what we refer to as Haldane effect. The principles are very simple. In Bohr effect, you can tell the oxygen affinity is inversely proportional to the concentration of CO2 and H plus. Similarly, your carbon dioxide affinity also will be inversely proportional to the oxygen concentration. So these are the two things that are very important to understand in the first place. So this is what we refer to something called Bohr and Haldane effect. And you can see during this process, definitely, since bicarbonate is either produced, bicarbonate is always synthesized from CO2, or bicarbonate is utilized in both these conditions. There can be movement of bicarbonate either outside the cell or inside the cell, depending on whether it's Bohr or Haldane effect, or whether it's a peripheral tissue or whether it is the lung. So this is what we refer to as something called a chloride shift. Again, this chloride shift is very important for RBC, because without that, the bicarbonate can neither move out of the cell or the bicarbonate cannot be moved into the cell, because movement of bicarbonate out and in of this inside the cell is actually quite important to understand. Quite important to perform all this process in the first place. So this is what we define as Bohr effect and Haldane effect. And I told you in brief detail about the chloride shift also. Apart from that, so the Bohr effect, apart from the Bohr effect and the Haldane effect, you have some other thing called a double Bohr effect. Double Bohr effect, so which happens during the pregnancy. Double Bohr effect is seen during pregnancy at the placenta fetal circuit. Placenta fetal circuit. So this is what we refer to as a double Bohr effect. So typically what happens in a double Bohr effect is when, I told you in a Bohr effect, carbon dioxide and hydrogen concentration increasing, the oxygen affinity will decrease. Similarly, when carbon dioxide concentration and H plus concentration are decreasing, the oxygen affinity will increase. So what really happens is the transfer of the blood happens in the placenta, so isn't it? So placenta will contain varying concentration of oxygen and carbon dioxide. Similarly, the fetal side will contain a varying concentration of oxygen and carbon dioxide. There is a two-side Bohr effect that is happening, that pushes the carbon dioxide into the maternal circulation and takes the oxygen back into the fetal circulation from the maternal blood. So these kind of two effects that are happening for the transfer of oxygen and carbon dioxide on the placental side as well as the fetal side is what we refer to as something called a double Bohr effect. So if they ask you where you see this double Bohr effect, which is a very important MCQ, you are going to see in the placental and fetal unit or the fetoplacental unit. So this is where you, in that area, that is where you see the double Bohr effect. So after knowing the double Bohr effect, the next final thing is to understand about the oxygen hemoglobin dissociation curve. That's called ODC, otherwise referred to as oxygen hemoglobin dissociation curve. So why this curve is very important, this oxygen hemoglobin dissociation curve? So because there are a lot of things you are going to understand. So if you want to simply draw the oxygen hemoglobin dissociation curve, I can draw something like this, because your affinity of oxygen depends on the PaO2, partial pressure of oxygen. So let me put two stacking lines like this. So one I can tell as the PaO2 on one side, that is the partial pressure of oxygen, and second one I can write as SaO2, that is the saturation of oxygen in the hemoglobin. So you can see initial part of the curve will be little bit flat, and it start at 0. Initial part of the curve will be little bit flat, and at a point of time there will be a vertical takeoff, and there will be a point of time where there will be a vertical takeoff will be there, and after that it again going to become blunt and it's not going to increase any further. So this is what we call it as the sigmoid shape of the oxygen hemoglobin dissociation curve. So this is what we call sigmoid shape of the ODC. That's called oxygen hemoglobin dissociation curve. So there are a lot of terminologies you have to understand from this oxygen hemoglobin decision curve or ODC. So what are the terminologies? It's important to understand. So first thing to understand is initially why this is flat, and later on why this is flat, and only in the center why it is taking off vertically like that, which means even minor changes in PO2 in this area is going to cause a massive change in the saturation of the hemoglobin. But initial part, change in the PaO2 is going to cause only very little change in the hemoglobin concentration. Only very little change in the saturation is there. But here, for the same change, you are going to get a dramatic change in the saturation. So why this is? In physiology, you would have studied that there is a phenomenon, something called as cooperativity. So what do you mean by cooperativity? Addition of one oxygen molecule to the hemoglobin is going to sequentially increase the affinity for the next hemoglobin molecule, next oxygen molecule. For example, addition of one oxygen to the hemoglobin increases the affinity of the hemoglobin for the next oxygen, incoming oxygen. Similarly, addition of two oxygen increases the affinity of hemoglobin for the third oxygen. Similarly, addition of three oxygen molecules is going to increase the affinity of hemoglobin for the oxygen for the third oxygen molecule, fourth oxygen molecule. So like this, the affinity keeps on increasing with addition of the oxygen molecules. Remember, hemoglobin cannot carry more than 4. The maximum is the 4 oxygen molecule, that much only it can carry. So initially, it is said to be in tense form. So which means initially, without any oxygen, with all the oxygen are released in the hemoglobin molecule, it's only in the deoxy state. Initially, it will be in the tense form. Deoxy form means it's a tense form. So because it's in the tense form, it's very difficult to load oxygen. The first oxygen will be very difficult. The moment you load one oxygen molecule by increasing the partial pressure of oxygen, after that it's a smooth picture. So you are going to smoothly increasing the oxygen attachment to the hemoglobin. This is what we refer to as something called cooperativity. And later on, because of complete saturation, so because of fully saturated hemoglobin, all the 4 slots are occupied by oxygen already. So in this condition, you are going to get a flat curve again. So that is the reason why initially also it's flat, later on also the mid part is the one that is going to have a sudden increase in the oxygen affinity, as well as sudden increase in the saturation of the hemoglobin with oxygen. So this is what is going to happen. So this is the explanation. So there are a lot of things, and one important terminology what you have to know is there is something called a P50. There is something called a P50. So what do you mean by P50? So P50 means the partial pressure, the PaO2, the partial pressure of oxygen at which the hemoglobin is 50% saturated. The partial pressure of oxygen at which the hemoglobin is 50% saturated, this is what we refer to as P50. So this partial pressure at which the hemoglobin is 50% saturated is what we refer to as something called a P50. Normally P50 is very important because with the help of P50 only you have to actually tell the right shift as well as the left shift. So suppose normal P50 is approximately around 26 to 27 millimeters of mercury, which means this is the point where the hemoglobin tends to be at least 50% saturated. So this is the point. So this is what we refer to as something called the P50. So normally 26, 27, I can simply write it as something called 26.7 millimeters of mercury. So this is the exact value where the hemoglobin is at least 50% saturated. This is the point. So suppose if the P50, if I tell if it is more than 26.7 millimeters of mercury, if the P50 is more than 26.7 millimeters of mercury, which means if it's increasing, if the P50 is increasing to this point, I can tell the ODC shifted to the right and the patient is having reduced affinity or more release of the oxygen. So suppose if the P50 is less than 26.7, or you can write more than 27 to the right and less than 26, that like that also you can tell. So if the P50 is less than 26.7 millimeters of mercury, then which means the P50 is here, less than 26.7. So if you ask me, this is 26.7, this is more than 26.7, and this is less than 26.7. In this condition, the ODC will, which means it has shifted towards the left. So that's what means. Ideal definition of oxygen hemoglobin decision curve shift to the right as well as left is actually should be defined based on the P50 value only. P50 value more than 26.7 indicates shift to the right. P50 value less than 26.7 is going to tell the shift to the left. So which means what are the conditions that are going to tell you? For example, you can see this slide. What are the conditions that will shift the ODC towards the right? For example, in this condition, this is the P50 here. I have given average of 27. So here, this is the P50 for this particular thing. So which means it has shifted to the right. Here, if you see, this is the P50 that is 10 in this hypothetical example, which means the oxygen hemoglobin decision curve is shifted to the left. So whenever it shifts to the right, it means, if you see, there is reduced oxygen affinity, which means there is increased release. That's what I tell a mnemonic for a beginner to start with. Whenever R right means it's release, which means right means release. So that's what is very important. So what are the conditions that causes the oxygen shift to the right? Again, it is given in the diagram. You have increased PCO2. I told you by Bohr's principle, you have something called Bohr effect, isn't it? By Bohr effect, I told you increasing CO2 and H plus is going to reduce the oxygen affinity, isn't it? So definitely increase CO2 and increase H plus, which means your H plus is increasing means pH is decreasing, or simply I can write it as acidosis. Acidosis and increasing carbon dioxide is going to shift the oxygen hemoglobin dissociation curve towards the right. Similarly, increase 2,3-BPG, again I told you, increase 2,3-BPG is going to reduce the oxygen affinity and it's going to precipitate the oxygen release, or is going to facilitate the oxygen release. And the 2,3-DPG has more affinity for deoxyhemoglobin compared to oxyhemoglobin. All these things we have discussed in the last video itself. Deoxyhemoglobin compared to the oxyhemoglobin. So the affinity will decrease and the release will increase, obviously, with 2,3-DPG. And similarly, increased temperature is also going to cause shift to the right, because the release will increase. Affinity will decrease and the release will increase with increase in the temperature, increase in the body temperature. Apart from that, certain other things that causes right shift I have not mentioned. So what are the other things that can cause shift to the right? So other things, like for example, you can tell something called low affinity hemoglobins. Certain low affinity hemoglobins can cause shift to the right. So what are the low affinity hemoglobins? Similarly, I told you there is something called a HB Kansas. Example I'm telling you, there are a lot of variants of low affinity hemoglobin. One of the important examples of low affinity hemoglobin is something called a HB Kansas, which is going to shift the hemoglobin curve towards the right. Similarly, exercise is there. You can imagine exercise like it's going to increase the body temperature, so automatically, and it's going to also produce lactic acidosis, which is going to increase the H plus and decrease the pH. Because of that, you can remember it's going to shift the curve towards the right as well. And similarly, high altitude can shift the curve towards the right. Similarly, you can write high altitude, there will be hypoxia. Hypoxia can precipitate lactic acidosis, isn't it? So you can remember like that also. So whatever you remember, it's okay. But these are three additional conditions apart from this diagram, which is important to understand. Similarly, left shift means there is increased affinity and reduced release. Which means left means hold. It holds the oxygen. It does not release the oxygen at all. So what are the conditions that reduces the oxygen affinity? Similarly, I told you by Bohr's principle or Bohr effect. This is very obvious, like whenever your CO2 is decreasing or H plus concentration decreasing, that is what we call as increased pH, and that is what we call as alkalosis. In this condition, definitely the ODC is going to be shifted towards the left. And low CO2, respiratory alkalosis, definitely will shift the ODC towards the left. Similarly, reduced 2,3-BPG, reduced temperature, and very importantly, some alterations in the hemoglobins is also there. Some altered hemoglobins like HbF are going to have increased affinity. Certain example, HbF is going to have increased affinity hemoglobin. So example is HbF. Even your myoglobin is going to have comparatively high affinity compared to your normal adult hemoglobin. So myoglobin you can write. So then you can write certain things like carboxyhemoglobin is going to shift the oxygen hemoglobin dissociation curve to the left. At the same time, you have something called HB Barts, simply. For example, this will discuss about HB Barts and thalassemia, that is called gamma-4 tetramers, which means these patients will not have any alpha chains around in fetal life, because this is a type of alpha thalassemia where their 4 gene deletion will be there, where only alpha chain will not be there at all, only gamma chains will be synthesized in the fetal life. So which means they tend to precipitate and they produce gamma-4 tetramers called hemoglobin Barts. So this is going to have extremely high affinity, even more compared to that of the fetal hemoglobin itself. So that's why it results in complications and death in utero. We'll discuss in detail. So this is what we call HB BARDs. And similarly, you have something called carboxyhemoglobin. Then you have something called methemoglobin. I mean, many people pronounce this as methemoglobin. Actually, it's not methemoglobin. Methemoglobin is different. This is what we refer to as something called a methemoglobin. Then you have something called a HB Chesapeake. I already told you Chesapeake is one of the examples for congenital high affinity hemoglobins. Apart from that, even one important condition, but often many people forget, that is called hypophosphatemia. Hypophosphatemia. This also is very important factor, hypophosphatemia. So this also can shift because this is something very important to understand, but many people do forget. Hypophosphatemia also can shift the oxygen hemoglobin dissociation curve towards the left. And this ODC has tremendous application, and a lot of applications are there. We have clearly discussed a lot of things about this ODC and its importance in the respiratory medicine topic itself, in the pulmonary medicine section itself, in the respiratory failure part. But apart from that, a lot of importance are there. For example, a patient who is having a persistently low saturation. I'm telling you, the patient is having a persistently low saturation. I'm doing a ABG, person is having persistently low saturation, which means the PaO2 is fine, PaO2 is okay, PaO2 is fine, and PaCO2 is also fine. But the patient is doing okay also, patient is doing well in ICU. Let us see this ICU case. Patient is doing well in the ICU, but the saturation alone is persistently low. What do you suspect? Very common thing in ICU. What are you going to suspect? I'm going to suspect acidosis. As simple as that. Because in acidosis, what is going to happen is there is going to be shift towards the right. So which means the moment it shifted towards the right, even though the PaO2 may be okay, but still the saturation is going to be persistently low, because the reason is in acidosis the hemoglobin is not going to hold the oxygen at all. Hemoglobin is not going to hold the oxygen at all, and it's going to cause definitely low saturation. For example, let us assume at the same 60, let us see here in this diagram to understand better. So for example, if you have a 60, so this is the normal oxygen saturation, but if the curve has shifted to the right, at the same 60 millimeters of mercury, you are going to have a low oxygen saturation only. This is the saturation without acidosis, and this is the right shift because of acidosis, and this is the saturation because of acidosis for the same PaO2, which means a persistently low saturation in ICU in a patient who's doing well may be just due to acidosis itself. So that is the condition that you have to rule out. Many times my interns used to ask me, sir, the patient is only having low saturation, but the patient is doing very well, okay. So I'll check for the bicarbonate and check for the acidosis, check for the pH, do an ABG and find it out. So that's what the idea is. So this is one clinical example which I'm telling how the the oxygen hemoglobin dissociation curve helps in your real time. So there are a lot of similar examples are there. And similarly, there is one thing where I will usually ask the question that why respiratory failure is defined as, for example, whenever your PaO2 is less than 60 millimeters of mercury, this forms the definition of a critical PaO2, as well as this forms the definition of something called a respiratory failure. So what is the reason for that? So why this is called a respiratory failure? So again, if you take the oxygen hemoglobin dissociation curve, so this is the curve, isn't it? So you take the oxygen hemoglobin dissociation curve, and I already told you it is sigmoid in shape, and initially and later on it will be flat, and the in-between part is the one that is going to have a maximum change in saturation in comparison to the PaO2 change. So here the PaO2 change is only this much, but your saturation change is that much, which means the delta is going to be very big here. The change is going to be very big here in this region. So let us assume a patient is suffering from a respiratory failure due to some lung issue or some other issue. Let us assume. So initially PaO2, let us assume it is 100. So let us assume this is the PaO2, and the PaO2 is 100 millimeters of mercury, and the saturation at this point tends to be 100%. 100% is the saturation. As the PaO2 keeps dropping, fine, PaO2 drops to maybe now 80. So if you see the saturation decline, it's not that much, isn't it? So you can see the PaO2, even though it declines by 20 millimeters of mercury, the saturation may be 94, 92% maybe. I'm just telling as an example. This is not exact thing. Arbitrarily I'm telling you, it's not decreased that much. Maybe 92, 93 maybe. Not that much decrease, maybe 94 even. Similarly 70, not much change. You can see if it's 70, again it's not going to be that much change. 60, not that much change. So you can see here at 60, still the saturation is a nice maybe 90, 91% or 88%. Still it's okay. It's not that much. But this is at 60 millimeters of mercury. This is a PaO2, 60 millimeters of mercury. But the moment your PaO2 drops below 60, you're entering the steep part of the curve, isn't it? The moment you enter the steep part of the curve, your saturation is going to decline much faster. For example, the moment you come to 50, you can see the saturation drops to maybe 70%. There is a 20% drop in the saturation because you are entering the steep part of the curve, the part of the curve where the change is going to be the maximum. So that is the reason the definition of respiratory failure or critical PaO2 becomes 60 millimeters of mercury, which is very important to understand because your goal of treatment of respiratory failure, for example, a patient is suffering from respiratory failure in ICU, your goal of treatment is going to be to maintain PaO2 of more than 60 millimeters of mercury. This is the goal for treatment in critical care scenarios in a patient with a respiratory failure. That's the goal. That's it. So you have to maintain PaO2 more than 60 millimeters of mercury. So like this, you have so many, things that you can apply on the ODC and so many things that can change the ODC and so many things that can alter the ODC, which is again very important. You can talk a lot of things, but still I think this must be sufficient for your exams as well as when you're going to practice. This must be enough. You think about the ODC. So with this we can conclude with this particular section on the basics. So next thing we'll be discussing more on the pulse oximeter section and the variant hemoglobins, which is again is a very important topic for your exams.